Okay, I'm connecting to YouTube. Okay. Okay, we're on YouTube. Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning. This is Dr. John Bennett broadcasting from Miami Beach, home of Neurosurgical TV. We're honored with the presence. This is a collaboration between Neurosurgical TV and the Alliance of Comprehensive Neurovascular Surgeons, the ACoNS, headed by David Giotti, and he's going to be moderating the proceedings and take it from here. So, okay, Divya, it's all yours.
Thank you, John. Good evening, everyone. Myself, Dr. Devi Jyoti, consultant neurosurgery and endovascular neurosurgery at Yasoda Medicity, Delhi, India. Welcome you all to the third of the series of webinars conducted under the Alliance of Comprehensive Neurovascular Surgeons, EGs. And over the last few couple of sessions, we had this focused on the importance of being dual trained and how it shall benefit our patients' outcome by being unbiased in our approach towards cerebrovascular pathologies. So moving ahead with our next session, to chair today's session, we have a few eminent people. The first of all, I'd like to have the privilege of having with us Dr. Anil Karapurkar, sir, the head of neurointervention at Bridge Candy Hospital, Mumbai. He has been the founding father of Indian endovascular neurosurgery. With decades of experience, expertise, and leadership, he has shaped the endovascular training program across national and international corridors. We welcome you, sir, to this webinar.
Thank you.
Next, as always, we have with us Professor Anita Jagatia, ma'am, the head of neurosurgery, G.V. Pant Institute of Postgraduate Medical Education and Research, a great teacher, mentor, and always enthusiastic about training the next generation. Welcome to the webinar, ma'am. And next, we have with us another hybrid cerebrovascular surgeon, Dr. Dinesh Sethi, working as professor in the Department of Neurosurgery at Guru Tegh Bahadur Hospital, Delhi, another residency teaching program focusing on comprehensive cerebrovascular training. Welcome to the webinar, sir. Now, moving ahead to our first speaker, Dr. Sunghan Kim. He is working as assistant professor in the Department of Neurosurgery at Bucheon St. Mary Hospital, College of Medicine, Catholic University of Korea. He did his residency from Severance Hospital, followed by fellowship in cerebrovascular surgery from the same center. He obtained his PhD from Yonsei University. His interests include neurointervention, microneurosurgery for cerebrovascular pathologies, ischemic stroke, cerebrovascular hemodynamics. Besides being an accomplished cerebrovascular surgeon, he's been a good friend, mentor for young surgeons. Welcome, Dr. Sanghan. The screen is yours. You can go ahead with your presentation.
Yeah, thank you for introducing me. And okay, can you see my slides?
Perfect.
Okay, I'll start. Hello everyone, and thank you for inviting me to this ACoNS meeting. My name is Sunghan Kim from Bucheon St. Mary's Hospital in Korea. Today, I'll talk about endovascular approaches to ICAS-related acute large vessel occlusion. Let me briefly introduce Bucheon St. Mary's Hospital. It is one of the 8 branches of Catholic University of Korea, which is one of the biggest medical schools in the country. My hospital is located in Bucheon, which is a satellite city of Seoul, the capital of South Korea, and it's about a 7.5-hour flight from India. The neurosurgical department at Bucheon St. Mary's Hospital is highly specialized in the field of cerebrovascular disease. And 7 out of 10 faculty members are dedicated as cerebrovascular specialists. demonstrating our strong focus in this area. We also provide both short-term and long-term visiting fellowship programs that are open to international physicians. Now, let me begin with the main part of my talk with an overview of ACoNS LBO. Before I begin the main part of my presentation, I would like to acknowledge that this presentation was prepared based on the teachings and the research contributions of my mentor, Professor Byung-Moon Kim. ACoNS LBO is common in Asian populations. Unlike embolic stroke, ACoNS LBO represents a stenotic disease process, primarily resulting from atherosclerotic plaque rupture or insider thrombosis. And then residual stenosis commonly persists even after mechanical thrombectomy in ACoNS LBO cases. So consequently, the risk of a vessel reocclusion is substantially elevated, ranging from 30 to 70%. And the underlying mechanism of reocclusion involves platelet aggregation secondary to flow stasis and then turbulence at the site of a residual stenosis. So paradoxically, in ACoNS, repeated endovascular device manipulation activates the platelets and then irritates the diseased vascular segment, thereby further promoting reocclusions. While mechanical thrombectomy for ACoNS LBO generally follows a standard treatment principles, several critical considerations distinguish it from conventional mechanical thrombectomy procedures. Foremost, the early recognition of ACoNS as the underlying etiology is of paramount importance, as it guides appropriate procedural planning and then prevent futile repeated attempts. And because ACoNS carries a high risk of residual stenosis and reocclusion, anticipatory rescue strategies to manage these complications are essential for achieving optimal outcomes. So let's start with the first key point, early detection of ACoNS LBO. Recognizing ACoNS from the beginning is very important because if we can suspect ACoNS early, we can avoid unnecessary repeated thrombectomy attempts. We can find several important clues that help us to predict ACoNS LBO, both in angiographic findings and in clinical features. First, let's look at the location of the occlusion. In a normal artery, embolic clots usually stop at the branching site. This is the natural pattern. However, if the occlusion is at the trunk of the artery, it may suggest underlying ACoNS or an inside occlusion from plaque rupture. So branching site occlusion typically indicates an embolic mechanism, while truncal type occlusion is an important clue that strongly suggests ACoNS. Of course, there are exceptions such as a large clot extending into the trunk, but overall, this remains a usable diagnostic clue. So if you see an occlusion at the bifurcation site, such as the IC terminus, MC bifurcation, or basilar tip, we should suspect the embolic infarction. On the other hand, if it occurs at the IC trunk, MC trunk, or vertebral basilar trunk, we should primarily consider ACoNS-related occlusion. And in ACoNS LBO cases, we often see residual stenosis even after clot removal, usually caused by plaque rupture. So after achieving recanalization, we should always carefully check for any residual stenosis. To summarize once more, branching site occlusion in the healthy-looking vessel usually suggests embolic stroke. On the other hand, truncal type occlusion with the residual stenosis after recanalization should make us primarily consider ACoNS-related occlusion. In addition, several other angiographic and clinical features can help predict ACoNS LBO. These include the hyperartery sign absence of arterial fibrillation, and a lower NIHSS score at presentation. The hyperartery sign refers to an artery appearing unusually bright and thick on CT angiogram, typically indicating insider thrombosis. In ICAS LBO, the NIHSS score is often lower compared to embolic stroke because the vessel already had a chronic stenosis, allowing collateral flows to reduce the initial symptom severity. Together with the tendency for reocclusion, these features serve as an important diagnostic clue for ICAS LVO. Now, let's discuss how to manage the reocclusion problem, which is the most critical aspect of ICAS LVO treatment, with the particular focus on GPI and rescue stenting. The biggest challenge in ICAS LVO treatment is reocclusion. According to research, reocclusion can occur in up to 77% of cases, even after initial recanalization. Moreover, approximately 2/3 of ICAS LVO patients cannot be adequately treated with the standard mechanical thrombectomy alone due to reocclusion. Therefore, additional rescue treatment beyond the standard thrombectomy are absolutely necessary. So, furthermore, as shown in the study result, not only immediate but also delayed reocclusion were independently associated with the poor outcomes. Therefore, not only achieving recanalization, but also sustaining vessel patency in the postoperative period is crucial for favorable clinical outcomes. Now, let's examine the mechanism of reocclusion in ICAS LVO. Even after achieving initial reperfusion with the thrombectomy, the inflamed plaques remains intact. This site promotes platelet aggregation and ultimately leads to reocclusion. Therefore, in ICAS LVO, clot removal alone is insufficient. We need additional strategies that target these underlying pathological processes. In ICAS LVO, reocclusion arises predominantly from severe stenosis, where inflamed plaque provokes platelet aggregation at the diseased site. To overcome this, we need two key strategies. First, inhibit platelet activity with the GPI. Second, secure adequate luminal gain through rescue stenting or angioplasty. Several studies have demonstrated that rescue stenting in ICAS LVO improves functional outcomes without increasing symptomatic intracranial hemorrhage risk. This evidence supports rescue stenting as a reasonable adjunctive method to standard thrombectomy. However, rescue stenting is a double-edged sword. If reocclusion occurs after stent replacement, it can actually worsen outcomes. Therefore, maintaining stent patency becomes critical for procedural success. To address reocclusion after rescue stenting, intra-arterial GPI is frequently employed. GPI inhibits platelet activation, while rescue stenting provides adequate luminal gain. As shown here, the combination of a rescue stenting and the GPI achieves the highest recanalization rate and the optimal clinical outcome in ICAS LVO. Furthermore, GPI is effective not only when administered intraarterially during the procedure, but also when then continued intravenously afterward. As shown here, postoperative IV tirofiban significantly reduced the early reocclusion and improved the clinical outcomes in ICAS LVO patients without increasing hemorrhagic risk. Therefore, you need to consider maintaining IV GPI post-operatively as part of your comprehensive management strategy for ICAS LVO. This diagram illustrates a mechanism of action of a representative glycoprotein 2B3A inhibitor such as tirofiban. Tirofiban is a GP2B3 receptor inhibitor which blocks the final common pathway of a platelet aggregation by preventing fibrinogen from cross-linking platelets. Whereas an anticoagulant acts on the coagulation cascade, tirofiban directly targets the platelet aggregation itself. This makes IV GPI particularly important for preventing reocclusion in ICAS LVO, since reocclusion often results from platelet aggregation triggered by inflamed plaques. Tirofiban, marketed as Aggrastat, comes in a 50 ml liquid vial containing 12.5 milligram. For preparation, we usually take a 25 ml, which is half the vial, and diluted it with 100 ml of a normal saline or 5% dextrose, creating a final concentration of 0.05 milligram per ml. We typically start with an intra-arterial dose of about 0.3 milligram, and the maximum is around 1.0 to 1.5 milligram. After the procedure, weight-based intravenous maintaining dose is continued. However, rescue procedures are not always beneficial and may at times precipitate additional risk. To anticipate this, intra-procedural flat panel CT can serve as a usable tool. If there is no enhancement on flat panel CT, this typically indicates intact blood-brain barrier integrity, suggesting a stable clinical situation. Under these circumstances, GPI and the rescue stenting can be performed with greater safety. Moreover, if the flat panel CT aspect score is 5 or lower after initial recanalization, administering GPI is generally futile and then potentially harmful, since low aspect increases hemorrhage complication risk. In such cases, rescue treatment should be discontinued. As an alternative, angioplasty with balloon alone or stenting without GPI may be considered, although these approaches carry a high reocclusion risk. Now, let me summarize the key principles that we've discussed today. In ICAS LVO, achieving initial recanalization is usually not the problem. The real challenge lies in maintaining vessel patency. So please remember these three essential principles. First, early recognition of ICAS during the procedure. Second, appropriate rescue therapy, GPI and the rescue stenting when indicated. Third, maintaining stent patency with optimal post-thrombectomy antiplatelet management. By following these principles, we can significantly improve the outcomes in this challenging patient population. Thank you for your presentation.
Thank you, Dr. Sundan, for a nice presentation. I'd like to ask the panelists any comments regarding the presentation, the topic. Anybody having any question can actually put in the chat box.
Dr. Anil Karapurkar here.
Yes, good evening, sir.
Good evening. May I make comments or ask a question? So
Okay.
how many of your patients, Dr. Kim, thank you so much for your presentation. It was very nice, and I think you made things very clear that ICAD is much more common in our part of the world than it is in the West. But my question is, how many of your patients have received thrombolysis when you take them up? Have they received altiplase or tenecteplase? In your country, do you use tenecteplase or is it altiplase that you use?
In Korea, you usually use actylase, conventional forms of TPA. Oh, you're muted. Sir, could you tell me again, because you are muted now?
Sorry. So, if the patient has received altiplase, you still rely only on the contrast enhancement after to decide whether to do the stenting or not, or do you still go ahead?
Sir, could you please tell me your question one more time, because from the beginning, your voice was muted.
Okay. So altiplase or tenecteplase, if that has given, does it change your approach to whether you do stenting or angioplasty post thrombectomy?
You mean do you are you asking me the safety regarding the IV TPA and then using tarafiban simultaneously? And it's one of a common issue that can be that tarafiban is used for during the procedure, but actually it's pretty much opposite to the current guideline. But I think guideline, the timing that made a guideline is pretty past compared to the people that can commonly use the tarafiban or something, GPI. And then practically we can see almost every people show the very feasible result, because actually then IV TPA's half-life is very short, and then also tarafiban the half-life is pretty short, and we can carefully use intravenously, checking the condition of individual patients using like a flat panel CT or something very special tool. I mean, it's not always safe, but with the selected patient with you can achieve a very much feasible result. But there's no other way to improve the outcome for ICAS patients, because there's no other way to keep the patency of a vessel. So I think it's very helpful, and soon in the future, guideline may be changed, because these days many practitioners commonly uses IV TPA and then tarafiban simultaneously. That's my opinion.
What about IV cangrelon? Have you used IV cangrelon, the parenteral antiplatelet?
In Korea, most medication have to be used under medical reimbursement, so it's not allowed in Korea. Just that clopidogrel is allowed, so I don't have much experience with that medication.
And how often have you brought a patient back and done the angioplasty or stenting at a later date?
You mean for ICAS patient?
Yes.
And so if it is recognized as ICAS at the beginning, and we can suspect the ICAS from the beginning at the emergency department, and if it is high suspected as an ICAS, I always prepare when and then how to deploy stent, and then how to give them an IA tirafiban. And because thrombectomy alone is not sufficient to keep the patency, and then it's hard to show you the exact rate of stent deployment, but the high percent of a patient for my patient uses a stent, and then even with the angioplasty, but almost always use the tirofiban if it is not it's not an contraindication.
Because what we prefer to do is angioplasty.
Yeah.
We prefer to avoid a stent. So what we do is we do an angioplasty and we wait for about half an hour, 45 minutes. If the artery does not slow down or shut down, then we don't do the stenting at that sitting. We do it at a later sitting after 3 weeks. Because we are worried about hemorrhage. You pointed out that you use contrast, and if there is no enhancement after contrast, then you use it. But we try not to do the stenting in the same sitting. So we call the patient back after 3 weeks, and post-op, we try and keep the BPA slightly on the higher side so that you prevent a restenosis, or even if there is mild restenosis, there will be adequate perfusion.
Yeah, that's a very good point, I think. And using the angioplasty alone or with the stenting depends on the practitioner discretion. But some people say that the angioplasty for acute period, for ICAS period, has a little risk because we don't know the original diameter of a vessel. So hard to select the size of a balloon, and then has a little risk of a rupture during the procedure. And then mechanical dilating causes has some risk. So people use that opinion, usually prefer to use a stent. I think using balloon or stent post-op might be good, and the most important thing is keep the IV trial even after IV post-operatively. I think it's very important.
So we underdilate. We don't go to the full diameter of the artery. We always underdilate. Yeah.
Okay.
Thank you very much.
Thank you.
Very, very nice. Thank you.
Yeah, hello, Kim. It was very nice presentation. And I just want to ask Dr. Karapurkar, like you said, you have to wait for 3 weeks to do the stent and whatever, the rescue stenting if you feel that it is not opening up or the what you have opened up the artery that is not maintained. So don't you think that 3 weeks is a very long time? And we have found that they re-stenose within a week's time if we do not address them immediately.
So I'm talking to all of you regarding the acute occlusion patient, not a chronic patient. It have to be totally separated. And for the acute period patient, first, if the recanalization has accomplished, I first prepare to use IA tirofiban, and then wait and then see if it works. And then if there's pretty much amount of patency without any stenting, just with the tirofiban, I think it's good. But it's hard to define when it'll be occluded, and so if with the keep the condition, checking the condition during the procedure very long time, if it is secured for the patency, I think it just left without any angioplasty or stenting, just keeping the tirofiban post-operatively. But there's a little, there seems a risk of reocclusion. I think I decide deploy stenting during the procedure, not waiting post-operative period. Yeah. That's
So,
my strategy.
Means you are relying more on the IV tirofiban post-operatively, right?
Pardon me?
The stent that you use is a self-expanding stent, Dr. Kim? Dr. Kim, you use a self-expanding stent?
Yeah, I usually prefer to keep IV tirofiban, and then for the stent, I usually use a solitaire because we can use a detachable stent like a solitaire AB or FR, and because we using the solitaire, we don't need to switch the stent, but there's no special stent. You can use Enterprise Neuropom Atlas, and then whatever you can use efficiently might be good.
Because we have the Credo here in India. The
Yeah.
Credo, the Credo is it has some radial force, and it is a good self-expanding stent. The Credo.
Yeah, self-expanding stent is enough, I think. Yeah.
What is the long-term outcome in these patients?
Yeah, pretty nice. And then actually my mentor, Dr. Byung-Moon Kim, recently published regarding long-term outcome of rescue stenting on American Journal of Neuroradiology. So you can check the result, briefly introducing the result. Almost over 90% of patients kept good result with the patient patency and then good MRS. So I think if the stent patient there's no occlusion right after immediate postoperative period, the patency keeps a long time, and then they secures a very good outcome.
Thanks, Kim. It was very good presentation. Thank you.
Thank you.
Thanks for your, it is very nice presentation. But how you treat with patients having mild symptoms, not presented with acute stroke?
You mean the chronic?
Yeah.
So
with mild symptoms.
You might ask me the incidence of stent deployment for the chronic ICAS patient, and then I don't like to deploy stent for the chronic ICAS patient because of the risk of a complication. So I think keep the stenting as a last resort, and then there is first try to use medication, and then if there's a very special and selected patient, I try to use a stent, but if bypass surgery is possible, I think I prefer to do bypass surgery rather than stent deployment. But it's very depends on the individual situation, so hard to tell you the concrete, simple answer. Sorry.
Thank you.
Yeah, thank you.
Okay. Thank you everyone for a nice discussion. Now, moving ahead with our next important topic, mechanical thrombectomy in acute stroke. We have with us Dr. Naufal Basir, a senior consultant, Department of Neurosurgery, clinical lead, endovascular neurosurgery and stroke intervention at Aster MEMS, Calicut, India. He obtained his formal neurosurgical training from the prestigious All India Institute of Medical Sciences, New Delhi. He followed that with fellowship training in cerebrovascular surgery and endovascular neurosurgery from St. Mary's Hospital, Catholic University of Korea. A truly comprehensive neurovascular surgeon himself. Welcome, Dr. Naufal Bashir. Welcome to the webinar. The screen is all yours.
Thank you, Divya, for the kind invitation and the introduction. Good evening, all. Thank you for joining this session. I'm talking about mechanical thrombectomy, not from a purely theoretical standpoint, but in a way that is practical and useful, especially for beginners who are new in this field. We'll cover the topic in three important aspects: the workflow, the devices, and case selection. So we all know why mechanical thrombectomy, because IV thrombolysis has limitations. As we know, it only achieves recanalization in about 30% of the large vessel occlusion. The treatment window is very narrow, just 4.5 hours from the symptom onset. And due to multiple contraindications, only about 15% of the patient actually qualify for intravenous thrombolysis. So mechanical thrombectomy, which directly removes the clot from vessel, we can achieve a up to 90% of successful recanalization rates, which is dramatically higher as compared to IV thrombolysis. And another key benefit is the extended window. That is, in carefully selected patients, we can go up to 24 hours. And as we all know, it's very evident. It has got a very good evidence-based backing. Multiple trials, the landmark 2015 trials like Mr. Clean, Escape, Swift, Frame, and also the Dawn and Diffuse 3 trials, which further extended the treatment window into 24 hours. So coming to the workflow, we need to have a clear benchmarks for the to set a workflow for a stroke patient in the emergency and in the hospital setup. So door to CT should be under 25 minutes. It has to be as minimum as possible, but 25 minutes is the highest cutoff that we should achieve. That is, any patient in whom CT is going beyond 25 minutes has to be evaluated, and we have to take corrective measures. So as a neurosurgeon, as a stroke interventionist, we have to take the lead and educate the staff in the hospital, from the security, from the person who wheels in the patient into the emergency, and the emergency physicians, nurses, CT technicians, everyone, the importance of this time. And we have to achieve we have to get the CT scan done as early as possible in every single patient. Then again, CT to groin puncture, from shifting the patient from CT to the cath lab, the counseling of the patient relatives, everything has to be done within a very minimum time, and it should not go beyond 60 minutes. So whatever time I am mentioning is the maximum time which we should, which is allowed. We have to make sure that it is as little as possible, and groin puncture to first reperfusion should be within 45 minutes. So in any hospital setting, especially in a comprehensive stroke center, there are two types of patients which come to our facilities. One is the drip and ship sort of patients, and the other is mothership type of patients. In drip and ship model, patients are first taken to the nearest primary stroke center. They get a CT scan, diagnosed to have acute ischemic stroke, and if eligible, IV TPA is started. Then if the further investigation shows that there is a large vessel occlusion, they are transferred into a comprehensive stroke center for thrombectomy. This pathway ensures patients don't lose the opportunity for early IV thrombolysis, but the disadvantage is the time delay before thrombectomy can be performed. In a center, in a place like India, where the comprehensive stroke centers are less, especially in a rural settings, this sort of drip and ship patients we have to promote. We have to do hub and spoke model. We have to have some spoke centers as attached to our hospital, to the comprehensive stroke centers. And if there are some physicians, we can tie up with them and start giving IV thrombolysis from that center itself. This at least makes sure that people get basic minimum treatment for the stroke. And the second way of patients are the mothership patients, that is the patients who directly come to your emergency department. In these patients, imaging, TPA, thrombectomy all happen at the same center. This actually avoids the inter-hospital transfer delay, but some of the patients whom we can give IV thrombolysis will be missed in mothership sort of patients. So for balancing, which is better, the answer depends on geography, transport times, and local stroke system organization. As I said, in urban settings with quick access to comprehensive stroke centers, the mothership model is often preferred. In rural areas, it is drip and ship plays a major role. Now coming to patient selection, who benefits? Not every stroke patient is a candidate for thrombectomy. We all know that patient selection is absolutely critical to have a very good result. And our aim is not to worsen the natural history. Our aim is to improve on natural history. If we have more patients with worse outcome than the natural history, then we have to look at our case, patient selection. So patient selection is very, very important, especially in a setting like Indian setting where the finance is also finance also plays a critical role in outcome. So confirmed large vessel occlusions is the first step, the first and the most important criteria for taking patients for mechanical thrombectomy. I'm not going into the MEVO and all these sort of the latest mechanical thrombectomy in medium vessel and all. I'm concentrating only on large vessel occlusion. The first step is confirming an LVO. The most common targets are internal carotid artery occlusion, M1 segment of the middle cerebral artery, and sometimes proximal M2. Selected basilar artery occlusions also are candidates for mechanical thrombectomy. Now coming to time window, one is early window. Early window is within 6 hours. Selection is straightforward. We all know that SCT and CT angio usually enough. But in extended window, we need to have other investigations like CT perfusion or MR perfusion. MR perfusion with ASL, that is non-invasive way of doing MR perfusion, where you can do it quickly. That is also very good in extended window. We have done so many cases with arterial spin labeling MR perfusion methods, and the selection criteria with ASL found to be very useful for extended window period patients in most of the time. Clinical criteria, we also need to look at the clinical profile. NIHS should be generally be above 6, meaning moderate to severe deficits. The patient should have a good baseline MRS of less than or equal to 2 before the stroke, and a reasonable life expectancy, usually more than 6 months. Exclusion factors, a large established infarct core with aspects of less than 6 is usually a red flag. Hemorrhagic transformation is a contraindication, and severe medical comorbidities or high procedural risk may also make thrombectomy inappropriate. So patient selection is about balancing urgency with judgment. The right patient at the right time can have a life completely transformed by thrombectomy. Now, we all have this, we all know that there is a critical role for imaging, especially for patients in extended window. In the early window, non-contrast CT is good enough. For extended window, you need to have a CT or MR perfusion in order to select the patients for mechanical thrombectomy. Beyond 6 hours, it allows us to identify the infarct core, which is already dead tissue, and the surrounding penumbra, which is still salvageable. So we need to make sure that there is a significant amount of salvageable brain tissue. Then only we should go ahead and do mechanical thrombectomy. In a patient with a large core, there are studies which shows that there is benefit, but in Indian scenario, I don't think we should go ahead and do large core thrombectomies, because usually the outcomes are not very good. Now coming to overview of mechanical thrombectomy devices, we know the first generation coil retrievers, which included the Mercy retriever. They feature
I think he's got muted. He should unmute himself.
Yeah, unmute. please. Oh, I think he dropped off. No, are you there? You have to stop. There you go. Okay.
Yeah, I don't know. Just a minute.
Okay. You're on your way. Okay.
Okay, I don't know how I left.
Okay.
So
You're getting there. You're getting the next step.
So coming
There
to
you
the
go.
overview of mechanical thrombectomy devices, we have the first generation retrievers, that is the Mercy retrievers, which had a efficiency of around 30 to 50%. Then the second generation, which
Whoop. Looks like you fell off again.
I think he gets stuck in that slide.
Yeah, I think it may be the connection, the Wi-Fi. Yeah. Oh, wait a second. There we go. You're good to go.
is it okay?
Yes.
Okay, I don't know what is happening. So, so these are the stent retrievers which are available, and most of us use Solitaire, Trevo, or Embotrap these days. And the aspiration devices. The aspiration devices include aspiration catheters, which are large bore flexible catheters with large for flexible catheters like Penumbra, Jet 7, Cat 7, etc. And the vacuum systems, which can be dedicated vacuum pump to provide continuous suction. Then combined approaches, Solumbra sort of approach where we use Solitaire along with stent retrievers. So what are the tips for beginners to avoid common pitfalls? Catheter navigation, we should use road mapping for all catheter advancement. Maintain a stable guide catheter position for support. Navigate very gently through the tortuous anatomy to prevent dissection. Continuous distal access catheters for improved support. Then again, regarding optimizing retrieval, always use balloon guide catheters whenever possible. It reduces the distal emboli by 60%. Allow 3 to 5 minutes for the stent to integrate before retrieval. This is very important, rather than just keeping the stent in place for just for a few seconds and taking it out. You keep it for 3 to 5 minutes. This also maintains perfusion in that time, and then let the clot be integrated into the stent, then retrieve. And maintain constant aspiration during retrieval. This is also very important. You have to have a flow reversal using the balloon guide catheter, or else you can apply 50 ml syringe at the guide catheter and aspirate during the retrieval of the stent. Consider switching technique before after 2 to 3 unsuccessful.
You're not audible again.
No, Paul, are you there? You fell off the audio. Okay. No file. Could you reconnect again, please? It must be the Wi-Fi connection, I think. Just wait a second for him to come back. This is a tough one. Go ahead. You're back on.
I don't know.
Yeah, you're on. You're fine.
But it. Yeah. So, preventing complications, we have to limit the retrieval attempts ideally to less than 3 to reduce the vessel trauma. Control blood pressure. I will be coming to that in next slide. Maintain for just monitor for contrast extravasation indicating perforation. Minimize contrast load, especially in old age patients. Optimizing the retrieval, that is always use balloon guide catheter, as I said before, and allow 3 to 5 minutes for stent to be there so that the clot gets integrated into the stent. Team dynamics is also important. Clear communication between the team members is very important, and also standard protocols for emergency management of complications should be there as a protocol. There are multiple emerging devices and techniques, which includes combined system with and advanced stent designs, specialized catheters, etc. The key workflow integration elements include successful mechanical thrombectomy, requires coordinated system of care that extend beyond the procedure itself, pre-hospital notification, rapid triage, standardized protocols, and seamless handoff between specialists is very essential for achieving optimal time matrix and patient outcome. The safety and complications to watch for. The main complication, dreaded complication, is vessel perforation or dissection. Incidence is 0.7 to 4.9%. You have to be gentle with the wire, catheter manipulation, and avoid oversized devices. Management include balloon occlusion. Sometimes you can use coil without detaching the coil. You can keep the coil at the site of perforation for some time, which usually settles the extravasation, and then taking out the coil, and also reversal of anticoagulation whenever there is rupture. Distal embolization, the incidence is 3 to 9%. The strategy is to use a balloon guide catheters to obtain complete flow arrest. If you don't have a balloon guide catheter, you can use continuous aspiration in the guiding catheter so that you have some sort of flow reversal. Symptomatic intracranial hemorrhage happens. The literature incidence is around 5%. Risk factors include delayed recanalization, multiple passes, and hypertension. Management is immediate CT, and maybe surgical evacuation might also be required in some patients. This is very important. Blood pressure management. Pre-recanalization, permissible hypertensive can be there to maintain collateral flow up to 185 millimeter mercury pressure. You shouldn't try to reduce that before recanalization. So post-recanalization, you should have a tighter control, that is a systolic BP of around 140 with a mean BP of around 110 to reduce hemorrhage risk from the reperfusion injury. Continuous monitoring with arterial line is preferred. Vasospasm can occur in some of the cases. Watch for sudden angiographic narrowing and be prepared to administer nimodipine or milrinone. The future directions and innovations include direct to angiography workflow. We have started doing that in few cases, especially in ultra early presenters, those patients who present within 3 hours of onset. We usually, with a significant deficit, we usually take them directly to the cath lab. Then mobile stroke units have come up in some part of the world. Then neuroprotective agents are also coming up. I will just show one case of direct to cath lab. This was a patient who presented within 4 hours of onset. 63-year-old male, right-sided weakness with inability to speak. NIHS was 21. We took him directly. 128 was the ED entry, and we directly took the patient into CT scan, to the flat panel CT of our cath lab. This is the video. I hope the video is working. So this is the flat panel CT, which shows no hemorrhage with significant NIHS. We gave him the IV thrombolytic agent, then went ahead with CT venogram, CT angiogram using the IV contrast, which showed an occlusion at the left M1 level. Then we went ahead with mechanical thrombectomy for the patient using the Solumbra technique. This was the DSA pre-mechanical thrombectomy, and then using the Solumbra technique, we could achieve complete recanalization of the left MCA with a TK3 recanalization, and the immediate post-op CT showed no contrast extravasation, no hemorrhagic transformation, no hemorrhage or no complication immediately. So with this direct to cath lab, we could achieve a ED entry of from ED entry of 1:28 p.m. within 35 minutes, we could achieve TK3 recanalization. So this sort of recanalization can happen only if we take patient directly to the cath lab. Coming to the summary, the key takeaways for the beginners will be the mechanical thrombectomy is now the standard of care for eligible large vessel occlusion stroke patients with strong evidence backing it. Remember, time is brain. Fast workflows and protocols are critical to reduce the delays. Patient selection, use imaging wisely, non-contrast CT to rule out hemorrhage, CT angio to confirm the occlusion, and perfusion studies for extended window cases. Begin with straightforward cases, anterior circulation, good aspects, early window before tackling more complex scenarios. Technical approach, get comfortable with both stent retrievers and aspiration techniques and know the strengths and limits of each. Balloon guide catheters can significantly improve outcomes and should be used whenever possible. Systems of care, clear protocols and communication between emergency, ED, neurology, new interventional team, and critical care are essential. Simulation training and quality improvement initiatives helps teams sharp and improve the results, overall results. Ultimately, success requires both technical skill and strong system level organization with ongoing learning as evidence and technology evolve. We need to understand that in neurointervention is not a cosmetic surgery. We cannot recanalize all the patients. We shouldn't make the natural history. We shouldn't have a result which is worse than natural history. So be aggressive, but you have to be clear in your mind that the result should be better than the natural history. So whenever you feel that you should stop, you have to stop. Thank you. Sorry for the technical glitches in between.
Thank you, Dr. Nausar, for a very nice, interesting talk. I'd like to ask the panelists to share their views.
May I, Dr. Karapurkar here, may I say something?
Yes.
Yes, sir, please go ahead.
Bashir, thank you for a very nice presentation. I think you covered everything very nicely. I would just add a few things. So the first thing is that when we ask for a CT or an MR, we rely more on MR. We don't rely so much on a CT. Especially in the posterior circulation, I believe a CT is useless. And if you ask 10 people to say what is the aspect score, I'm sure each one of the people who are reading the scan would come up with a different score. So I would insist, rather I would tell most patients, neurologists, ask for a CTA and ask for an MRA. Because in addition to the infarct, you need to know what is the cause and which is the artery which is occluded. If it is a small vessel, you don't need to go chasing after it. If it is a large vessel occlusion, you have to go chasing after it. IV will not help. So that's number one. We rely on an MR because in our hospital, we have made it a protocol that the scan will be done in 13 minutes. So supposing a patient is on the table just now, a scan is being done. As soon as that sequence is done, we take the patient off and we move the new patient, the stroke patient on, and we do the scan in 13 minutes. And we just look at the diffusion, the flare, the ADC, the AW, I have to look out to roll out hemorrhage and angio. And the neck angio is what really takes time. The head is done very fast. The DWI takes 1 minute, 2 minutes. The thing, and of course, flare is important because if there is a flare and diffusion mismatch, then it means that it is more than 4 hours old and you should be worried about hemorrhage. So these are the things that we look at. And as far as in our country, patients have to pay for everything. So as far as possible, we try and reduce the cost. So we use, as far as possible, a single device. So we always use, as you said, the balloon catheter. I think that is very important. So with the stent retriever, we always use a balloon guide catheter. If with 3 passes we don't get open the artery, then we add a second device. But we rarely use 2 devices to begin with. But there are a lot of people who always begin with 2 devices, always use 2 devices. So we don't do that. And we have a very high 60 to 70% recanalization in the first pass. One more word is about anesthesia. For dominant hemisphere and for posterior circulation, many times we have to use general anesthesia because the patients are very restless, they don't understand. So we have to make sure that the anesthetist is on board. We don't wait for them to come. Supposing we have a patient who needs to be done right away and anesthetist is busy somewhere else, we would start with the puncture, we would take the angiogram, and as soon as the anesthetist comes, if required, we would intubate and carry on from there, especially for dominant and posterior circulation steps. Anterior circulation, of course, we always do under local anesthesia. And as you mentioned, we always aspirate strongly on the guide catheter. Because many times we find a lot of stuff in the guide catheter. Not so much in the stent. In the stent also, but sometimes big gobs in the guide catheter. So we always strongly aspirate, as soon as we disconnect, we get the stent retriever into the Y, we aspirate strongly with a 50 ml or 20 ml syringe on the guide catheter and we get stuff. So I think this is what I wanted to add to what you have said. But your presentation was very good and I think it was quite comprehensive. Thank you.
I agree to most of the points by you, sir, because in Indian scenario, especially MRI is, we can go ahead with MRI because it will further select the patients whom we can have a bad results. Especially CT, we may not find the aspects so very well, and we might end up doing so many large score patients, which increases the treatment cost. I totally agree with your that statement. We should go ahead with, whenever possible, if we can get the MRI done early, I think we can go ahead with MRI even in the first 6 hours.
Important the A part of it. CT or CTA and MRI and MRA, because I see even in the city of Mumbai, many patients who get only an MRI done, not an suspected stroke. You know that the substrate is a stroke. Why ask for an MRI? That's a clinical diagnosis. You want to know what the size of the infarct is, where the exact location of the infarct is, and what is the cause of it. So for which you need an MRA or a CTA.
True, sir. I think in our setup also, we have moved to the MR protocol. One thing I'd like to ask, you mentioned about using a single device. wouldn't it be good that we should start with an aspiration first, then think of as the first device?
So whatever is your experience and whatever you are happy with. We are very happy with the stent retriever, so we have been not yet graduated. So we restrict because one is attached to the cost. The stent retriever is much cheaper. And when you use an aspiration catheter, it is more expensive. And inside an aspiration catheter, I don't like to go with a big catheter straight into the ICA or into the basilar. I would prefer to have a smaller catheter inside. So if it's a 7.2, you would have a smaller catheter inside so that you don't cause any dissection as you are going up, especially at the anterior clinoid to get past the ophthalmic. But very often the catheter gets stuck there, and to take it past that, you better to have a catheter inside. That's what we do. So we prefer to use and by choice, we always use a 6x30. We don't use a 4. We always use a 6x30 or a 6x40. We don't use even for an M1, we would use a 6x30. Of course, if you are going to a smaller artery like the M2, M3, then you would change over to a 4 or a 3. But as far as possible, we use a 6x30 or a 6x40 for M1, of course, for basilar and for ICA.
So you're
Are there
using larger size stent retriever, sir?
We have found
6x30 is
with
a
a
large size
440,
stent retriever.
with a 440, many times we find that it doesn't come. To switch to a 6x30, 6x40, almost always first pass it comes.
So which retriever you are preferring, sir? Which company? The Trevo or the Codred or which one?
We have been using a solitaire for a long time, so we are very happy with solitaire. But you can use whichever, but use a 6x30 or a 6x40. That is what I would.
So what is your experience also with the MCA? Are you cannulating both upper and lower trunk? Many times they are not able to open the both the trunks. Then
See,
what is the strategy like?
so you try and we don't use, as far as possible, we don't use 2 stents in M1 or MCA. So we use one. If required, we go for the other branch a second time. So if you are going distally into an M2, M3, then you would go with a smaller cap. So start with a 6, and usually with a 6 we are able to clear it out. If it is not, then of course you have to use a. And like I said, most of our patients have received RTPA, so it does act. So many times if it's a small thrombus which is blocking the artery, it goes distally and thrombus dissolves.
So one very practical question, sir, and to all the panelists. Like suppose in a place where there's a public sector hospital and there's a lab which is occupied for one case, and you get another case. Meanwhile, what do you do? How will you manage it?
Need a lab. Without a lab, how can you do it? You need a roadmap. You cannot work without. True that you don't see beyond the occlusion, but you still need a lab. So without a lab, so it is not possible. And what you have said, that's a practical problem for most hospitals, private or public. Lab has to be free.
I think we also need to maintain a good relation with
cardiologist.
Good relation with the other departments so that we can get their cath lab in such emergency.
Yeah. So one more thing, most people tend to reuse in India. So a stent retriever is something that we have reused, but very infrequently. As far as possible, we always reuse a new stuff. We don't use any old stuff. But stent retriever is one thing which you can reuse again.
A very good presentation, Dr. Naufal. Thank you.
Thank you, Dr. Naufal. Now, moving ahead with the next segment, in today's vascular board, we have with us Dr. Hemant Beniwal, Assistant Professor, Department of Neurosurgery from Savai Mansingh Hospital, Jaipur. He shall be discussing a couple of interesting cases to show how being dual trained actually helped them in approaching and selecting the right approach for the cerebrovascular pathologies. Over to you, Hemant.
Okay.
Please first share the screen. Click on the share your screen button first. There you go.
Hi, good evening to all. I am Dr. Hemant. Here we are going to discuss about two cases. I am from SMS Medical College.
Hemant, you have to take full screen. Make it full screen.
Sir,
It is
Yeah.
not full screen.
Yeah, full screen is bottom right. Bottom right. Click on one of those icons on the bottom right. Bottom right. Or you can go ahead just with this. We'll have to accept it.
So case one, we got a reference from the medical department, like a 54-year-old male patient who presented with the chief complaints of intense throbbing headache for 1 day and history of loss of consciousness, one episode, 1 day back while working in the field. There was no any significant additional history like seizure, trauma, no comorbidities like hypertension, diabetes, or coronary artery disease. But patient is a chronic smoker for last 10 years. On examination, patient was conscious, coherent with the intact GCS, stable vitals without significant deficit. So we did the radiological examination. On CT scan, we found the SAH in the bilateral sylvian fissure along with anterior interhemispheric fissure. So
Yeah,
we went
Hemant's
for
slide
the
is not
CT
moving.
angio.
Hello, Hemant's slide is not moving, and put it in the slideshow.
Okay, ma'am. Just a
Yeah,
second.
you have to click on each individual slide if you want to do it this way.
Sure. Is it okay?
Yes, yes, yes. Oh, go ahead, please.
So we choreography brain and we for the in the CT angiography brain we found there was the aneurysm on the distal anterior cerebral artery just in front of the genu, and like we took the DSA if it is. So on the CT angiography brain, we found that it was the aneurysm of the distal anterior cerebral artery, like we can see here at the termination at the junction of A2 and A3, just in front of the genu. So in the DSA, it is, yes, now it can be played. On the DSA, it was just same thing. Video is
Okay, it's not moving. Do you want to do it on the proper presentation mode at the bottom of the screen? There's four
So-
options. If we can do this correctly and put it on presentation mode. Go to the bottom
So
right. Go to the bottom right.
on the basis of the DSA, we decided to do endovascular coiling after taking consent from the patient and giving both options of coiling and clipping from the right side, as the aneurysm was filling from the right side. And so we put the hardware like short femoral sheath, after that long sheath and distal DAC catheter and micro catheters. And we decided to do coiling from the right side of the ACA, as aneurysm was filling from the right side. But there was, we found difficulty in the engaging catheter into the A1, as there was a sharp turn of A1 arising from the ICA at the bifurcation. Like this was the like U-turn. So we engaged the micro wire up to here, but we were not able to engage the micro catheter. So after that, after some time, we found that there was a cutoff sign at the origin of the A1, and it was looking like it was the thrombotic occlusion of the A1. So we stopped trying from this side, but we were worried about the anterior cerebral circulation. So we went from the left side. And on the left side, when we went, there was the filling of the aneurysm from left side also after the occlusion of the right A1. So we decided to do left side from the left side coiling. It was looking like it was a straightforward aneurysm flow in the aneurysm, and we can do easily. But it was not like that. Uh, After that, when we took 3D reconstruction of the aneurysm, we found that there was the occlusion of the ACoM, but partial there was the contrast flow is there, but we were not able to negotiate the catheter in the ACoM. So we were not able to do coiling from left side also. So after that, we decided to do clipping of this case. So we took this case immediately into the neurosurgical OT, and we did the clipping of this distal anterior cerebral aneurysm. From the right frontal craniotomy, we went anterior interhemispheric dissection, and after the securing from flow from the proximal and distal, we clipped the neck of the aneurysm. And this was the post-operative CT of the patient. So there was a little anterior interhemispheric bleed, but all assets we washed off, and there is a little hypodensity seen in the post-operative CT. And on the post-operative, patient was doing well. Patient was extubated immediately after surgery. He was vitally stable on nimodipine. We started and allowed only on post-op day second, and we started antiplatelet also on day second. And patient was discharged on day 5 without any deficit with antiplatelet drugs. So this was our first case in which we tried to coiling, but due to anatomical difficulties, we couldn't perform the coiling, and so we decided to do clipping, and we performed clipping, and patient went well with the clipping. So this is the case second. It was the 60-year-old male patient presented with chief complaints of headache for 2 days and history of loss of consciousness 1 day back, followed by altered sensorium. It was not a known case of any comorbidity. Headache was sudden in onset, severe in intensity, intermittent, diffuse in nature, doesn't relieve after taking medications, and but not associated with any nausea and vomiting. On examination, patient was drowsy, and it was the E2, V2, M5 GCS, but maintaining saturation on room air. Pulse rate was 68 per minute, and BP was 134/74, and bilateral equal reacting to light pupils. So on the we got the radiology already done from the medicine department, and we found on the radiology that there was a large ICH in the right frontal region, and with the flow voids in between the ICH, and there was the angiography also with the patient. So on the angiography, there was the AVM, arteriovenous malformation, with the large tortuous draining veins to the superficial and deep system both, and filling from the right side of the MCA. Like it was the filling trajectory of the AVM. It was the from the superior branch of the MCA and through upper M3 branches. But patient was having mass effect on the CT, and patient GCS was worsening. So we decided to do decompressive craniectomy along with the excision of AVM on the same sitting. So we did ICH evacuation and excision of AVM with lex duroplasty, and we didn't put the bone on the same sitting, and we decided to do interval cranioplasty. So it was our post-operative CT head that was showing the complete excision of hematoma and complete excision of the nidus along with the occlusion of the feeders. And on the post-operative status, patient was shifted to ICU. We tried to gradually wean off. On day 3, we had to do tracheostomy. On day 5, patient was GCS was E2. We tracheostomy, and following commands on the repeated asking with stable vitals. We discharged the patient on day 7 on the tracheostomy after making him understand the tracheostomy care. So this was our second case. In this also we performed first DSA, and after that on the basis of the patient condition and the large ICH with mass effect, we had to do open craniectomy and the evacuation of ICH and excision of AVM. So I am from the SMS Medical College. Here our neurosurgery department is a big department holding 7 units. In the 7 units, more than 20 faculties, and 14 per year we are having the residents. 6 neurosurgery dedicated elective OTs running from Monday to Saturday, and 2 neurosurgery dedicated emergency OTs. They are running round the clock, all 24 hours and all 7 days. And all type of neurosurgery work we are doing here. On the endovascular workflow, we are also doing endovascular. There is dedicated endovascular OT with the biplane machine. We are doing all 7 days on the availability of the cases, and availability of our team is all 24 hours. All 7 units are working endovascular work. In every unit, there is a consultant who is doing endovascular work. We are doing every type of work like aneurysm, AVMs, dural AVFs, and mechanical thrombectomy. Here, our head of the department, Dr. Manish Agrawal, and our endovascular work mentors are Dr. Tilochan Srivastav and Dr. Ashok Gandhi. Thank you so much. Thank you, Dr. Divya, for giving opportunity to present here at Neurosurgical TV and Comprehensive Neurosurgical webinar platform.
Thank you, Dr. Hemant, for discussing your case. Any of the panelists would like to have approached it differently in the 2 cases that he has shown?
Yeah, he said he was not. May I start? Dr. Anil Karapotkar here. Thank you, Dr. Hemant.
Good evening, sir.
When you get into the A1 or any intracranial artery for that matter, do you shape the wire?
Yes, sir. We shaped the wire.
You have to shape the wire according to the curve of the artery. And if you do that, many times you are able to get it. That is one way to do it. What we sometimes do is to make it into a complete U, make it like a U. And with that knuckle, go into the M1. And when it comes back, it goes into the A1. So these are
Exactly.
things you have to follow, because I don't think it should be very difficult to get into that right A1 in your first case. I think you have to learn how to do that. So if you can't get it in this way, you go with the knuckle into the M1 and come back, and just when you engage the origin, get the wire in. So you have to shape the catheter also accordingly. Not only the wire, but also the catheter. So this is my suggestion for that. And one disadvantage of being a surgeon is that you know that you can always clip the aneurysm, so you don't try very hard. So that is a disadvantage, I would say. But if you are doing endovascular, you should try, if required, struggle, but try and get your wire in. Of course, be safe. Don't be unsafe, but be safe and still try and get access, because these are from matter of access to the aneurysm.
Yes, sir, definitely it is a great advice. We engage our wire up to the A2 also, but when we were trying to engage the catheter over wire, then it was every time it was the pulling in the M2 because of that U-turn anatomy. But okay, definitely your advice we will follow, sir, and it will help us.
You should take the wire as distally as possible. Let the wire go
Yes,
beyond into the A2, let the wire go distally, then it will give support. The other
yes,
trick
sir.
is to get the guiding catheter up. Supposing if you have kept the guiding catheter low in the neck, try and get your guiding catheter, intermediate catheter, into the supraclinoid. Sometimes it can go all the way up to the supraclinoid ICA. So if you have a microcatheter inside and a wire inside, the whichever back you are using, this flaccid catheter you are using, you can get it into the ICA or even into the A1 or M1 if required. So I think advancing that DAC also gives you support so that the catheter
Yes, sir.
won't buckle into the M1, into the MCA.
Yes, sir.
That's just some suggestion. You have to try for it.
Sir.
Yes, sir. You're right, sir. Absolutely. When I learned from you only the making the U of the ACA and hooking the ACA, making the U the wire and then hooking the ACA. That is very true. And what did you do, Hemant? What did you do with the A1 was not visible? Then what did you do for that A1, the right side A1?
Yes, ma'am. Right side A1, when it was the block and it was looking like thrombotic occlusion, then we first we ensured that there was is there flow in the anterior circulation. So we went from the left side and took the DSA. So both ACA were both A2 were filling from the left side. So
The A1.
we tried.
What about A1? A1. What about the A1?
Yes, yes, ma'am. We did not do any intervention on the A1. We tried from the left side. We couldn't do on the left side because there was the narrowed ACoM. Contrast was going from there, but catheter was not negotiable. So we did clipping, and on the day second, we started the antiplatelet drugs.
So what was the post-op CT angio showing about the status of the opposite A1?
Post-op
Post-op
CT
CT angio.
A1,
Yeah, after clipping.
yeah, on CT angio, I didn't include, I think, but it was the A1 was the blocked, but anterior circulation was patent.
A1 was still
Yes,
occluded.
distal
The
was
right one was
patent, right?
still
You could do the CT angio and could see the status of the A1 because Hubner must be arising maybe from A1 or maybe because patient didn't have any deficit, maybe it was arising from the junction of the A1, A2. Yeah, that may be the
Yes,
thing.
ma'am.
And second, in your case, second case, could you do the 4-quadrant craniotomy rather than subjecting the patient for one more surgery after doing the craniotomy? Like it was correct decision that it's such a big hematoma and grade 1 AVM, you should always go for the surgery. So we can always go for 4-quadrant craniotomy that avoids the second surgery, and that is how young patient can be managed.
Yes, ma'am. It can be done, but we went thoroughly safer side that we did the decompressive, as there was the sometimes after AVM oxygen there is edema also, and there was already 2 days, so edema was developing and there was a significant mass effect. So we did the decompressive.
So, sir, what do you suggest? Like for DACA aneurysm, like they are of course difficult to clip also. And as he was showing, it is not the aneurysm. The vessel itself is disease, whether you go from outside or you go from inside the vessel. So nowadays, as it is said with the different hardware and all, and of course you could take that when your target is very distal. You could take distal access catheter that will support your micro catheter and all. Then you can cannulate the vessel. So what do you suggest, like these kind of aneurysms? Should we continue doing the coiling, like as the people are, more and more people are into this procedures, or we shall add the clipping as well to keep the art of clipping alive? So what do you suggest to us, being the neurosurgeon also?
You have to decide whether you want to keep the art of clipping, because DACA is a difficult aneurysm. If you're with neuronavigation, of course, it is easy. You can follow the artery and you can go and clip it. But if you don't have neuronavigation, it's not very easy to find a DACA. Sometimes a little tilt of the microscope, a little tilt of the head, flexion extension, and you may be in front of or behind. So DACAs are difficult. But today, with these catheters, wires that we have, it is not very difficult to get distally. So we do try and get as far as possible. And we do try and like I said, we have to shape the wire and we have to shape the catheter also. So you may need to shape the catheter as well to go distally. And many times for these DACA aneurysms, we have used a flow diverter. So we have used one of these small baby Vista Silk, or we have used a Fred Junior, and it has worked very well. Especially if it is a wide neck, you don't even need to coil unless it is recently ruptured aneurysm or a DACA unruptured. Many times we can just deploy a flow diverter in the pericallosal itself. It is usually in the fork between the pericallosal and the callosomarginal. So if you deploy an FD in the either depending on which way the aneurysm is into the DACA from the pericallosal into the pericallosal or pericallosal into the callosomarginal, and many times that is enough. But if you want to learn, keep your art of clipping also going, I think you should clip aneurysms. But these, I would say the MCAs should definitely be clipped as far as possible. We are still continuing to follow that. Most MCAs do get clipping. But the others, depending on how easy or difficult it is for surgery, and vice versa for endovascular, we decide. Today, most of our patients undergo endovascular other than MCA.
So what is your resurgery rate in these cases, sir? What is long-term follow-up and what is resurgery rate?
Not very good, not very high. Not very high. Maybe 10%. What are difficult are the basilars, the bifurcations. So basilar top, MCA bifurcation, these often come back. Even sometimes the ACoN, if the ACoN like the one that he showed, if it is like a bifurcation aneurysm, exactly in the fork, then they come back. But if it is sidewall, you don't come back so often.
What about IC bifurcation?
Same applies for IC. Any bifurcation aneurysm, the chances of recurrence are higher. So today in a bifurcation aneurysm, as far as possible, we use either a contour or we use a vein.
What is the experience with the contour or the neck stent with the coil? Like, are they good
We have mostly used the contour and we have used the web. We have not used the neck stent ourselves. But those who have been using it say that it is quite good. In the olden days, where we have done Y stenting and coiling also for these bifurcation aneurysms. But MCA, I don't like to have two stents in small arteries. Our arteries are smaller than the European or American arteries. So I am worried that too much metal inside the M1 will result in thrombosis there. So basilar is comparatively bigger. So basilar to P1 on both sides and a basilar top aneurysm being coiled and with a Y stenting is feasible. Or you can do an X stent so that you have only one arm in the basilar, one in one P1, the other in the other P1.
Thank you.
One thing I'd like to
Sir,
add actually, when it comes to identifying using navigation to pinpoint the DACA aneurysms, I think a couple of cases I had with when I was with ma'am, Anita ma'am, we could actually localize the DACA aneurysms with intraop ultrasound as well. Using color Doppler, you can actually see the flow as well. So that was one of the ways you can use to actually follow the trajectory, identify the trajectory to actually dissect out the DACA aneurysm as well. That can be one of the options as well.
And sometimes, typically, it can be difficult to know, especially if the arteries are tortuous, whether the aneurysm is on the left side or on the right side.
Yeah.
It can be sometimes very difficult. So it has happened to us that we have thought it is on the right side. We have gone all the way in, and then we found no, it's on the other side.
So that is why the clipping is better in these cases. So whether you go from right or left, you are there.
Yeah, that's true.
Yes. Sir, for negotiating this kind of A1 origin from ICA, this is my suggestion. Most of the time we make shaping the wire in S-shaped. The proximal S is more wider and the distal S is less. And while slide dancing the wire, we can easily negotiate through this kind of anatomy. Rather than making U-shape, we are preferring S-shaped.
Yeah. So always there should be a small little bend proximally. A little
Yes, sir.
proximally in addition to the distal bend.
Nufal, you had a question? Nufal, Bashir?
So,
Go ahead.
as
Before
we were
we
discussing clipping,
Yeah, go
when
ahead.
to clip,
yes,
so for me as a hybrid neurosurgeon, I found especially middle-aged wide-neck aneurysms better to clip, and especially in unruptured aneurysms, it is very easy to clip rather than in cases of acutely ruptured aneurysms. You go ahead and coil those aneurysms, and then maybe after 2-3 months, maybe put a stent and completely cure. So that is what is the strategy we follow now. I prefer clipping in unruptured, especially MCA bifurcation aneurysms in young patients, because it's very easy. You don't have to split the sylvian completely. You have to just open the sylvian at the area of the aneurysm, and you can easily clip those aneurysms rather than putting stent and doing platelets.
I agree with you. No.
so before we wind up, I've there's just one question from one of the attendees. I think Dr. Weber wants to know, is there any center in India where that gives specific training only for mechanical thrombectomy?
I don't think there is any center specifically, but Dr. Gigi Karakutam in Rajaji Hospital, Cochin, he is giving a 1-year training for acute stroke, basically for acute stroke and stenting. So you can contact Gigi. If you go to the net, you will find out. Gigi, Gigy in Cochin, Rajaji Hospital.
So that's all for today. Thank you so much, all the speakers, all the panelists, for your time on Saturday evening. Thank you so much for being with us.
Thank you.
For having us today,
And
Divya.
Divya, I would suggest that include Dr. Karapurkar in as many as webinars, because he's a very good teacher with a very extensive, vast experience, and considering the Indian scenario, or where the Asian countries where we have resource problems and all those other logistic problems. So
Yes,
we would
ma'am.
like to have you, sir, in the many webinars. Hope you will agree.
Sure. Thank you.
Thank you. Thank you,
Thank you.
everyone, for joining for the time. Thank you, sir. Thank you, everyone.
Okay, thank you very much, everybody. Divya, thank you for putting a great conference together. And thanks to all the panelists. And you're not done yet. There's another webinar coming up from Spain on this particular topic with Luis Ibor Lopez. It's a ground table with Demetrius Lopez from the Cerebral Vascular Stroke Center in Chicago. He's going to talk about endovascular treatment of normal pressure hydrocephalus and beyond. So stay tuned. The link is in the chat, and the information to get in the panel. So you can join in right in the panel on this webcast. And again, thanks, Divya. Thanks, everybody, for coming, and we'll see you in a while.
Thank you. Thank you.
Thank you. Okay.